Wala pa din.
Wala pa rin. Sira ba ang computer ko?
Di kanina nakagamit ka naman baka.
Ayun.
Entire screen.
Okay, can you see now?
Opo, Doc.
Okay. Bakit ganun?
Entire screen yung ginagawa.
Okay, so now we'll be talking about ARDS. This is very short. ARDS A stands for Acute Respiratory Distress Syndrome. So we will first define, then enumerate the common risk factor, discuss the pathology and the pathophysiology of ARDS, what would be the treatment strategy for ARDS, and the prognosis of patients with ARDS. Okay, so ARDS stands for your acute respiratory distress syndrome. So this is an acute lung injury that results in severe dyspnea of acute onset, presenting with diffuse bilateral radiographic infiltrates and refractory hypoxemia, leading to acute respiratory failure. So, the criteria for the diagnosis of ARDS is that there have to be the clinical presentation, the setting. So, the presentations would be acute shortness of breath. Usually, the patients will also appear with tachycardic, tachypnic. The clinical setting, this would be the different clinical conditions that would lead to the development ARDS, the radiographic appearance, and the lung mechanics that were in the patients have increased lung resistance and a drop in your gas exchange, and that means you have severe hypoxemia, but you're not supposed to have cardiovascular problem. Okay, so that means your patient's lung cardiac function should be normal. Okay. So clinically, the first symptoms of your patient is dyspnea, and that is the most common, and the most common sign is tachypnea. And of course, this is pulmonary edema. That's why on auscultation, you can hear crackles all over the lung field. And the clinical setting is either a direct lung injury or an indirect lung injury. The most common direct lung injury would be because of pneumonia, and the most common indirect lung injury would be somebody who have sepsis. Okay, radiographic appearance would be diffuse alveolar infiltrates more in the periphery. That's why we say that this is the butterfly or the bat wing appearance of the X-ray. And the lung mechanics is that the patients would have decreased lung compliance, and patients would present with severe hypoxemia that is refractory and normal vascular function. Pressure, that means your capillary wedge pressure should be less than 18 millimeter mercury. Okay, so the criteria is that your patient should have severe hypoxemia with acute onset, and the radiographic findings and absence of atrial hypertension. That means you do not have a cardiovascular problem. Okay, and in ARDS, we further subclassify the ARDS into mild, moderate, or severe. Mild meaning the PF ratio is less than 200, but is more than 200 but less than 300. Moderate if this is more than 100 but less than 200, and severe if this is less than 100. PF ratio. I hope you still remember how to calculate for your PF ratio. We talked about this in your in your midterm, right? Still remember? You forgot. Hello? You forgot or you still remember how to calculate for your PF ratio? Hello?
Remember, Doc.
Okay, so you remember. Okay, now because ARDS need to diagnose ARDS, we need arterial blood gas. Okay, and of course, sometimes we even have to measure the pulmonary capillary wedge pressure, and this would entail that the area that we are practicing in is
Hello po.
just a moment. Okay, so sometimes the area where we practice in do not have arterial blood gas. So in that case, we do not know the exact PF ratio. So that's why in Africa there is an wherein they do a study to for the use of autosaturation as a way to diagnose help in the diagnosis of ARDS. So this would be the new criteria for ARDS, wherein we can use the autosaturation. So this is for resource limited community. Okay. So the criteria for ARDS still hold true with regards to the clinical manifestations, the radiographic infiltrates, and the lung mechanics. And then the difference here would be the calculations of your PF ratio. Okay. So the patients would still have the same, but the calculations of your PF ratio, instead of the PF ratio that we use, we can use the saturation to your FiO2 ratio. And in that way, you can now, given without arterial blood gas, you can now use this new category specifically for the diagnosis of your ARDS. So in mild, okay, if the patient is not intubated, PF ratio should be less than 300, or a saturation to your oxygen saturation to your FiO2 ratio of less than 315 on high flow with flow of more than 30 liter per minute, or using a non-invasive ventilator or CPAP with at least 5 cm water at an expiratory phase. For intubated patients, okay, for mild, the PF ratio should be less than 200, more than 200, but less than 300. Okay, or you can use the saturations of your PaO, po- uh, oxygen saturation to your FiO2 ratio, wherein it is less than 350. Okay. And for moderate, between your less than 235, and for severe, less than 148. Okay. So this is if your auto saturation is less than 90%. Okay. And for severe, it have to be less than, okay. Oh, sandali. I cannot see it. Pwede ko ilipat. Okay. So um your modified for limited resources, it have the PF ratio of less than 315, or you can use your auto saturation of less than 95%. Okay, with neither a positive and expiratory device or a minimal device for your oxygenation. Okay. So example would be for these patients, okay, who is in shock but in distress, and in distress, mechanically ventilated, then it's easy to calculate for their PF ratio. But if your patient is not mechanically ventilated, then you can use your uh, saturation to your FiO2 ratio, and this would become 114. So this patient is now categorized as having ARDS. Okay, so while using face mask, okay, supplemental oxygen, and you can also use the new category without even if the patient is not mechanically ventilated if you are in a resource limited area. Okay, so that is your new definitions for your ARDS. For your, of course, this would still need you still need your further study for this category for use of this form of ARDS. Okay, so what are the different injuries that would lead to the commonly associated with the development of ARDS? For direct lung injury, as we have said, the most common would be your pneumonia. Usually, ARDS secondary to direct lung injury have more severe, okay, or poorer prognosis compared to lung injury secondary uh, a secondary lung injury compared to your direct. So prognosis wise, the indirect lung injury disease is having will have a better prognosis. Aside from pneumonia, what are other conditions that can cause direct lung injury that may lead to development of ARDS? This would be aspirations of your gastric content, contusions to the chest, drowning or near drowning, and inhalation of toxic substances like your ammonia. Okay, so this would be example for that direct lung injury. For indirect lung injury, as we have said earlier, sepsis is the most common, but other conditions such as multiple blood transfusion, multiple trauma, severe trauma, drug overdose, pancreatitis, and post-cardiopulmonary bypass surgery, okay, is also associated with the development of ARDS. So, although these have a better prognosis compared to your direct lung injury. So, what is the pathology of patients with ARDS? ARDS can be divided into three phases: the exudative phase, proliferative phase, and the fibrotic phase. So, the exudative phase, you have your changes also seen in the hyaline membrane, and proliferative phase, you have your interstitial inflammation, and as the term fibrosis imply, if you're in the fibrotic phase, then you would see fibrosis of the lung. So at the start of the illness, you still initially have edema first 2 days. So the exudative phase is the first 7 days of illness, wherein initially you have alveolar capillary injury, causing the disruption of the tight membrane of your endothelial cells, and destructions of your endothelial cells with destruction of your type 2 pneumocytes, okay, which would lead to a loss of the tight alveolar barrier, leading to the accumulations of pleural edema fluid in the lung parenchyma that is high in protein, in contrast to pulmonary edema secondary to an increased hydrostatic pressure, wherein you would have lower level of protein. And after the exudations of the fluid into the alveoli, you can also see increase of your pro-inflammatory cells, cytokines such as your interleukin 1, 8, and your tumor necrotic factor, including your lipid mediators like your leukotriene B4, and marked increase in your neutrophils. Sometimes in this phase in the peripheral blood smear, you would see a paucity of your neutrophils. So there would be a marked drop of your peripheral neutrophils also at this phase. Okay. And following this, you would see that there are aggregates of your protein and airspace forming cellular debris, causing and together with the dysfunctional cellular surfactant, this would now lead to the vascular obliterations by microthrombi and fibrocellular proliferation. Okay, injury to the vessels causing pulmonary hypertension, reductions in your blood flow to the ventilated portions of the lung, and increase in dead space ventilation, which can lead to the development of hypercarbia at the early stage of your ARDS. Okay, so the edema, alveolar edema, predominantly involve the more dependent portions of the lung, leading to decreased aerations and atelectasis, decreased lung compliance, which lead to increased pulmonary shunting and further deteriorations of your hypoxemia, causing the increased work of breathing. That's why the patients complain of severe difficulty of breathing. Okay. And difficulty of breathing usually develop within 12 to 36 hours after the initial insult. However, sometimes we see a delay by as long as 5 to 7 days. Okay. So at this phase, your patients would have tachypnea, increased work of breathing. So that means you would have increased use of accessory muscles of your respiration. You see a lot of retractions, and if this does not change, then this can lead to your development of your respiratory muscle fatigue, leading to your respiratory failure. Further deteriorations and leading to your respiratory failure. Okay, at this phase, you see there's uh, a lot of inflammatory cells and flooding of the alveoli and recruitment of more inflammatory cells into the alveoli and interstitial space of the lung. And there is also hyalomembranization formation in the in the basal portions of the lung. Okay. And this is followed by your proliferative phase. Okay, most patients would recover in this phase. So histologically, the first sign of resolution is in this can be seen in the initiation of lung repair. And most patients, okay, would show organizations of the alveolar exudates and shift from neutrophils to your lymphocytic predominant infiltrates, and you would start to see the proliferations of your type 2 pneumocytes along the basement membrane, okay, leading to the synthesis of new pulmonary surfactant and differentiation into your type 1 pneumocyte. So that means the lung would start to recover already. Okay. And however, despite the improvement, the patient will still be tachypnic, short of breath, and hypoxemic. So if your patients does not improve, then the patients will deteriorate and progress to the fibrotic phase of ARDS. Okay. Histologically, the presence of alveolar type 3 procollagen peptide is a marker of your pulmonary fibrosis. And this is associated with a protracted clinical course and increased poorer prognosis for patients with ARDS. Okay. So in the fibrotic phase, usually the patients would require, if your patients go into the fibrotic phase, the patients would usually require long-term ventilation support. And histologically, you can see extensive ductal and interstitial fibrosis, arsenar architecture markedly disrupted, leading to emphysematous changes like your large bullae. Because of these changes, the patient is also at increased risk for the development of barotrauma. So the patients would have increased risk of the or development of pneumothorax. And because of the fibrosis, the lung would further be harder to inflate, and there would now also be pulmonary increase in your pulmonary dead space ventilation. Okay, so this would be the consequence because of these changes. And there is intimal fibroproliferations in the microcirculations, leading to progressive vascular occlusions and further development of your pulmonary hypertension. Okay, so when we see patients with ARDS, obviously the first differential diagnosis that we usually have would be your cardiogenic pulmonary edema. But of course, one criteria for your ARDS is that your patient should have a normal cardiac function. So aside from your cardiogenic pulmonary edema, neurogenic pulmonary edema is also one of the considerations. Pulmonary hemorrhage, diffuse pneumonia or acute immunologic injury to the lung, or toxic injury to the lung, or among patients who have interstitial lung disease. Okay, but the most common differential would still be cardiogenic pulmonary edema. Okay, so radiographically, we can use this X-ray to help us distinguish whether this is a cardiogenic pulmonary edema or your ARDS by looking at these parameters: the heart size, vascular pedicle, pulmonary blood flow distribution, pulmonary blood volume, presence or absence of your septal line, presence or absence of your peribronchial coughing, air bronchogram, and the distributions of your lung edema, and presence or absence of your pleural effusion. So for ARDS, the heart is supposed to be normal in size. The vascular pedicle is also normal. Pulmonary blood flow is also normal. So would be the blood volume. There would be no septal line, but this is common in cardiogenic pulmonary edema. Okay, peribronchial coughing is also absent, but this is common in cardiogenic edema. Air bronchogram is commonly seen in ARDS. Lung edema is more in the periphery. That's why this is described as a butterfly or a bat distributions of the pulmonary edema, and pleural effusion is not common, but is common in cardiogenic pulmonary edema. Okay, so this is an example of your patients with CSF. The heart is enlarged, and the distributions of the edema is central. Contrast is the patients who have ARDS. The distribution is more in the periphery, like a butterfly or a bat. Okay. So after we diagnose patients who have ARDS based on the clinical presentation, the setting for the development of ARDS, and how do we treat? Okay. So the general principle of treatment for ARDS would be the recognition of the underlying conditions. So number one would still be treating the underlying conditions, minimize procedure and their complications, then prophylaxis against venous thrombosis, gastrointestinal bleeding, and venous catheter infection, prompt recognitions of the nosocomial infection, and prevent provisions of adequate nutrition. And while we are doing this, of course, we have to tie the patients over the injury. So we have to be able to maintain adequate oxygenations to the patients. So usually the patients would need oxygen support, okay, and a majority of patients would need mechanical ventilation to support their respiratory function. So if our patients is mechanically ventilated, the advice now is to start the patients on a low tidal volume of around 6 ml per kilogram body weight, the ideal body weight, okay, and maintain at an acceptable pH and O2 saturation, and mean arterial pressure to minimize complications of hyperperfusion, which may further cause problem to the patient. Okay, so patients usually are intubated, right? So the intubations and mechanical ventilation is usually because of a cardiorespiratory arrest. But if the patient does not go into arrest but have persistent hypoxemia of less than 60 millimeter mercury on supplemental oxygen given through a high flow uh, machine, then we may have to intubate the patients. Or if the patient is retaining carbon dioxide, or the patients develop metabolic acidosis, that means the patients have inadequate respiratory compensation, and we have to intubate the patients to assist the ventilations of the patient. Okay, so when we mechanically ventilate the patients at the start of the illness, we see a lot of patients with ventilator induced lung injury. And this induced lung injury is usually because of the over distensions of the alveoli repeatedly, what we call your volutrauma, and repeated recurrence of your alveolar collapse, which we term it as atelectrauma. Okay, because of this, the lung is we further cause injury to the lung instead of helping the patient. So to avoid this, okay, we have found out that if we ventilate the patient using low lung volume, we can avoid the alveolar over distensions, and repeated distensions and collapse can lead to the deteriorations of the pulmonary function. Okay, so the advocate now, we have shown quite a good improvement in the outcome of patients with ARDS using the 6 liter or 6 ml per kilogram body weight tidal volume. Okay, so the low tidal volume, okay, will results in those results in significant reductions of mortality and morbidity. Okay, and to prevent the alveolar collapse, we counter this by giving PEEP. Okay, so PEEP is being used to decrease the collapse of the lung. Okay, without increasing your oxygenation. Other measures that we can use to prevent alveolar collapse would be the prone position or the inverse ratio ventilation. But PIP and the low tidal volume so far have a better outcome compared to the other one. Okay, so that is usually how much PIP do we give the patients? Usually it is around 12 to 15 PIP. So theoretically, this is the optimal PIP for ARDS. So if we want to calculate PIP, then we have to have with the patients intubated, we have to check for the upper inflections and the upper deflections of the pressure volume curve and the lower inflections of the pressure volume curve, and maintain the PIP at around between the upper and the lower point of inflections and deflections. So it is around 15 to 30. So for less, because if we give a lot of PIP, it may also cause harm to the patient. So we do not want to give too much PIP. Okay, we can gradually, if we introduce 15 cm PIP and the patient's not improving, you can gradually increase your PIP. Okay, but usually if you reach 30 or 35, that's already very high, and it would be associated with a poorer prognosis. Okay, so the inverse ratio, usually we do not use this. We'll not go into this anymore. Okay, and dynamic hyperinflations. Okay, usually this is also your PIP, but of course we already instituted PIP. We do not want the patients to have an over distended lung. So we have to try to be controlling this. So the PIP is used to prevent the collapse and improve the outcome. Okay. So the so far the improvement in survival has been seen with the lower tidal volume. Okay. So other ventilation setting that you can use, but of course, this is not it is not being used very often. This would be your ECMO, extracorporeal membrane oxygenation. So usually this is a last resort that we use for patients who have ARDS. And of course, this has been shown to improve their survival. Of course, your patients, you have to be uh, familiar with this. Okay, not all center can have the ECMO because you have to have a team for you to really be good in providing ECMO to the patient. But this can improve the survival and give time for the lung to regain its function. Say, so aside from the management of the lung using low tidal volume, we also do not want to overload the patients with fluid, because in the first place the patient is already edematous. So we want to further minimize the pulmonary edema. Okay, so with that we would all be able, if we minimize pulmonary edema, we can improve the pulmonary mechanics, shorten ICU stay, shorten durations of the mechanical ventilations, and this is also associated with a lower mortality compared to a overload of your fluid. Okay, of course, we do not want to cause severe hypoperfusions, which may lead to multi-organ failure. So restricting fluid and use of diuretics, okay, can be used, but this is usually limited by hypoxemia and hypoperfusions of your critical organ. Okay, so corticosteroids have been tried for a long time, and recently they have tried to give the corticosteroids at the end of the first phase of ARDS, and they claim there is some improvement in the ICU survival, but the long-term survival is not that significantly affected. So there, we still need more time to study about this form of treatment. Okay. Other therapy have been tried, like surfactant replacement, giving of nitric oxide to try to open up the blood vessels. Okay, but this has not shown any improvement at all. So presently, based on the evidence available, okay, the recommendations would still be your low tidal volume ventilations, which is a grade A recommendation, early use of neuromuscular blockades to decrease the combating of your patients with the ventilator. This is a B recommendation. And low arterial filling pressure. This is again a B recommendations. This is based on the proper management of fluid. Okay, not recommended so far would be your surfactant supplement and your steroids. Okay, so mortality, risk of mortality is affected by the advanced age. Of course, as you are older, the higher would be the risk of mortality. Your increased Apache score is also associated with higher mortality. Pre-existing organ dysfunction, direct lung injury, and early elevation of dead space is also associated with higher mortality among patients with ARDS. So, they found out if your patient is 75, the mortality rate is around 60% compared to 20% in somebody who is less than 45 years old. If you are 60 and have sepsis that leads to development of ARDS, there is a threefold, threefold higher risk of mortality. So that means as you grow older, your risk of dying is higher. Okay, pre-existing organ dysfunction like your liver disease, alcohol abuse, chronic immune suppressive treatment therapy, renal disease, cirrhosis, and sepsis will increase, all of this would increase your mortality. So mortality among among ARDS patients is around 40 to 65%. Actually, although this is still high, this has already improved significantly. Improvement is largely attributed to non-pulmonary causes, with sepsis and non-pulmonary organ failure accounting to more than 80%. Okay. And improvement in survival is largely secondary to advance in the care for sepsis and infected patients and those with multiple organ failure. Okay. And poor prognosis or predictor of poor recovery would be somebody who have extensive lung injury, low static respiratory compliance, needing high PEEP, and long durations of mechanical ventilations, and patients with very high lung injury score. All of this would point to a poorer prognosis. Any questions? Hello?
Opo, Doc.
Okay, so very good. So the next topic is your. I'll stop sharing first. So I